Okay, so let's continue. Of course, we cannot end the discussion of ventricular system and CSF without discussing the blood-brain barrier. So, the blood-brain barrier was discovered in 1882 by a scientist named Paul Ehrlich. No? His experiment was injecting animals with the dye tryptan blue. It is an intravascularly injected vital dye which stains. So he found out in his experiment that tryptan blue actually stained all the tissues in the body except for those located within the central nervous system, so the brain, the spinal cord. And so he came up with a conclusion that there is such thing as a blood-brain barrier through which not all substances can pass. No? But actually nowadays we know that the blood-brain barrier is actually not an absolute barrier. No? It is permeable, but permeability is inversely related to the size of the molecule, of course, and directly related to the lipid solubility. Because as we know, cell membranes within our body, they accept lipophilic molecules and, of course, not very much hydrophilic molecules. Size of the molecule, of course, you would expect a smaller molecular size could more easily traverse the blood-brain barrier compared to molecules of larger size. And in fact, those with a molecular weight of 60,000 daltons and higher remain in the blood and does not pass the blood-brain barrier. It is almost impermeable to plasma proteins and other organic molecules. No? And so, actually, also blood-brain barrier, but like I said, because the blood-brain barrier actually continues throughout the central nervous system as well as the peripheral nervous system, you also have continuous capillaries. So it's actually more than blood-brain barrier because it's also a blood-spinal cord barrier and a blood peripheral nerve barrier because of these continuous capillaries. So what makes up a continuous capillaries? No, so in the extracellular spaces around neurons, the capillaries are actually composed of the following. So we have the endothelial cells, you have a continuous basement membrane, and of course glial cells, astrocytes that adhere to the outer surface of the capillaries. And the endothelial cells within these capillaries have tight junctions between them that allow for the formation of the blood-brain barrier. So remember, you have three types of capillaries in the body. You have continuous capillaries, you have fenestrated capillaries, and you have sinusoidal capillaries. Sinusoidal capillaries usually found in liver, spleen, where endothelial cells are really, they have a lot of open spaces to which molecules and intravascular components can easily communicate with the extracellular system. Whereas in fenestrated capillaries, these are formed by endothelial cells that have windows or fenestra. No? So they allow some passage of molecules, but probably not of cellular components, but molecules easily pass through. Whereas in continuous capillaries, located in the central nervous system and peripheral nervous system, as well as in some skeletal muscle tissue, the endothelial cells have tight junctions. So water and other organic molecules, proteins cannot easily pass through them. So clinically, the ventricular system, as we discussed, it can be investigated clinically, usually using a CT scan or an MRI. So you'll learn this in the clinics later. Usually, preferred method is MRI, but of course, being a developing country, sometimes patients cannot afford an MRI. And if needed, intracranial pneumography. So let's just touch a little bit on pneumography. This is essentially the replacement of CSF with oxygen or air. Why? Because oxygen or air is less dense than CSF or brain tissue, thereby allowing the ventricles as well as the cerebral gyri, they can be visualized more easily because of the contrast of the density of air with the nervous tissue and nervous tissue. Whereas, of course, if normal CSF, because it's liquid, because it has water and some organic molecules, sometimes it can be more difficult to distinguish nervous tissue from CSF. Okay, so clinical application. Hydrocephalus. Remember, hydrocephalus is an abnormal increase in CSF volume within the skull, together with an increase in intracranial pressure. So, it is usually due to an abnormal increase in CSF formation, blockage of CSF circulation, or diminished absorption. But you have to remember that abnormal increase in CSF formation is a very rare occurrence. So usually this happens in choroid plexus tumors, no? But otherwise, cerebrospinal fluid production remains at a very constant rate. So it is not a very common occurrence that you have increased production. Usually, hydrocephalus is due to blockage of the CSF circulation or diminished absorption. So blockage and diminished absorption. Rarely, hydrocephalus occurs with normal CSF pressure, and these patients usually exhibit compensatory atrophy of brain substance. So if you investigate these patients on MRI, you will note atrophy of the cerebral or the brain substance. So hydrocephalus, abnormal increase in CSF volume and pressure within the skull. So remember, why does this happen? Why is there compensatory hypoplasia or atrophy of the brain substance? So if you remember, we discussed the Monroe-Kelly doctrine. Monroe-Kelly doctrine, that the skull only has a fixed amount of volume, or the skull has a fixed volume. So any expansion of one of the three key contents of the skull, what are the three key contents of the skull? So you have nervous tissue, you have cerebrospinal fluid, and you have blood, which is circulating within the venous sinuses and the circle of Willis and the arteries in the brain. So those are the three key components within the skull. Any one of those that takes up more space than it should, the other two have to give way. So there are two types of hydrocephalus. You have non-communicating hydrocephalus, which is when there is raised CSF pressure due to blockage at some point between its formation and its exit through the foramina and in the roof of the fourth ventricle. So this is a non-communicating hydrocephalus, meaning it is within the ventricular system. It does not communicate with the subarachnoid space. In communicating hydrocephalus, there is no obstruction that exists to the outflow from the ventricular system, and the CSF freely reaches the subarachnoid space and is found to be under increased pressure. Okay? Non-communicating hydrocephalus, the ventricular system and the subarachnoid system do not communicate, so the blockage is within the ventricular system. No communication between CSF pressure of the ventricular system and the subarachnoid space. Whereas communicating hydrocephalus, there is no obstruction that exists within the ventricular system, and the ventricular system and subarachnoid space are communicating with each other. So very easy to remember. In subarachnoid blockage, usually this may be blocked in the vertebral canal. So a spinal tap, forming a spinal tap is a great value here. Normal opening pressure of a spinal tap is around 60 to 150 millimeters of water. If CSF is blocked, normal variations in pressure is diminished or absent. So how do you know that? How do you know that? You have the Queckenstedt sign. What is that? So usually when you perform a spinal tap, the patient is in a fetal position. No? What the Queckenstedt sign is, it is the absence of increased manometric reading of CSF on compression of the internal jugular vein. So normally, if you compress the internal jugular vein, you reduce what? You reduce drainage from the central nervous system, right? From the skull, you diminish the venous drainage from the skull. remember that CSF is absorbed by the arachnoid villi or the arachnoid granulations, which drain into the dural venous sinuses, specifically the superior sagittal sinus. No? So once you compress the internal jugular vein, you would expect a decrease in cerebrospinal fluid absorption within the venous sinuses, because now what happens is that the venous sinus pressure is greater than CSF pressure, so CSF absorption is diminished. So what you would expect is an increase in manometric pressure, meaning there's increased pressure on your tap when you compress the internal jugular vein. But Wettenstedt sign is the absence of that. So this usually signifies that there may be blockage of the subarachnoid space. That's why there is absence of variation. So normally there is variation. When you compress the internal jugular vein, you expect CSF absorption to decrease and CSF pressure in your spinal tap should increase. But the absence of this variation means that there is a blockage in the subarachnoid space. And this is known as the Wettenstedt sign. So here is a very simple illustration of the spinal tap. So remember, your spinal cord ends at what level? Usually the superior border of L3. So spinal tap is usually done either in between L3 and L4 or L4 and L5, because at those levels you only have the cauda equina. You don't have the body of the spinal cord anymore. No, so spinal tap. In spinal tap, these are the layers that you pierce before reaching the subarachnoid space. So you have skin, you have superficial fascia, you have the supraspinous ligament. Supraspinous ligament. Where's the supraspinous ligament? This is the superficial fascia, and you have the supraspinous ligament here. So at this layer, okay, so supraspinous, above the spines. So these are the spines of the lumbar vertebrae, and this is the supraspinous ligament. And then next you have the interspinous ligament, so between the lumbar spines. So supraspinous, above the spines, interspinous, between the spines. And then next you have the ligamentum flavum, and then areolar tissue containing the internal vertebral venous plexus. Of course, finally you have dura mater and arachnoid mater. The depth to which the needle will have to pass will vary, usually from 1 inch or less to a child to as much as 4 inches in an obese adult. So I think Dr. Arancel has a very wide experience doing spinal tap because she's an anesthetist. And so that's my lecture. Thank you for listening, guys. Please study the last lecture, meninges, and this lecture, ventricular system and cerebrospinal fluid. We will have your evaluation exams. I think on Wednesday or Thursday, either of the two. Okay, thank you.